Good afternoon, and thank you all for joining us today. Welcome to the Ear Research Foundation's Hearing Education Series. Today's webinar is Causes and Treatment of Vertigo. Today we are joined by Dr. Fechtner and Dr. Wazen, and they will be presenting a lecture. At the end, we will take some questions. Please submit them via chat, and they will be answered at the conclusion of the lecture. Thank you.
Good afternoon. Can you hear me okay? Looking good. Okay, I got my AirPods in, so I was hoping that was going to work. So let me go ahead and share my screen. I've got a PowerPoint that we can talk through here. Hold on a minute and okay, here we go. So my name is Dr. Fechtner. I am the outgoing fellow here with the Silverstein Institute, and I was going to give an introduction to vertigo causes and treatments. The first part of our agenda, we're going to talk about defining dizziness, what it means and what we as ear physicians try to figure out when you're coming to our office to ask about dizziness. We can talk a little bit about the anatomy of the balance system, and then balance disorders and their treatment, both a little bit about the inner ear and then other patients with balance issues that we see. I want to start with this picture just because the concept of balance is a complicated one. It's a complicated system. If you think about watching any child who's learning how to walk, it definitely doesn't happen in a day. We kind of can do well with balance for most of our lives. Sometimes at the end, different problems happen in different sections. So when we're evaluating patients for balance, we think about all these systems. So here, the blue arrows are the inputs. What comes in that helps us understand where our body is in space? Some of that is vision. The eyes, of course, show you where you are. The vestibular labyrinths are referring to the inner ear system, the sensory system that your brain uses to figure out where your head and body are in space. The somatosensory system is more the system of touch and feel, what your feet are feeling that tells your body what your balance is doing. And then that information all goes into the brain, is processed and organized, tells you where you are, and then the brain has some reflexes and structures that it also uses to help maintain balance. So here in the purple arrow, autonomic pathways, that's the fancy way of saying that automatic part of the nervous system that changes how your blood pressure responds to your position in space. So for example, if you go from sitting to standing up, all of a sudden your blood vessels need more support to keep the blood in your head. So that way you don't pass out immediately when standing up. There's the vestibulo-ocular reflex, which I'll talk a little more about later, how the back
recorded. You are muted. You can mute or unmute yourself by pressing *6.
Hi, I think I'm back. Ooh. Hold on a minute. Are you guys getting the same echo I'm getting? Okay, let me see if I can.
It's better now. I don't hear an echo anymore. I don't hear that funny sound anymore.
Hello, testing. Okay. Let me see. Can you hear me okay with this? This is just using my computer system. A little better?
Yes.
Okay, that'll be better. I think my Zoom just crashed and then my my AirPods got confused. So let me get back into my slide. What was the last thing you heard me say? Okay, here we go. Long story short, the balance system is a complicated area. So when you come in to get evaluated, you're going to get a lot of questions where the doctor or the therapist is trying to figure out what you're feeling. So some of those things we try to figure out. One, definition. So vertigo, we commonly think of as a spinning feeling, like either you feel the room is spinning around you or you just feel that feeling of spinning, which is another sensation that can come from a couple different places. Commonly the inner ear, can also come from the brain, central processing. Some medications can give you that feeling. Another different feeling we try to figure out that you're also having is a lightheaded feeling, more of that blood pressure dropping, brain's not getting enough oxygen feeling, which can also have different causes. And then more of an imbalance, disequilibrium feeling where you feel off when you're walking. There's something going on more with motion, but you're doing okay at rest. So those are different parts of what you're feeling that we try to figure out so that we know how to help and how to diagnose what's going on. If we look more at the anatomy of the balance system, so in the inner ear, so within the skull and close to the brain, the main sensors of the vestibular system are called the utricle and the saccule, and then these semicircular canals. So those are right next to the hearing system. This part is the cochlea, which helps us hear. Right next to it, this balance system. Part of it helps sense motion in space. That's more linear, kind of more flat motions up and down and moving. That's the utricle and the saccule. Those use kind of little calcium rocks to, it's very cool and sophisticated. It uses it almost as a gravity system sensor. The balance canal system uses fluid within a canal, and the brain uses the movement of that fluid in relationship to the harder outer covering to figure out acceleration of the head. So that's more a head turning feeling, and the brain uses the difference between the two sides to tell where the head's moving in space and to automatically adjust the eyes. And I talk about that anatomy of the balance system because it ties into some of the treatments of our balance disorders. It also ties into some of those reflexive eye movements. So I briefly mentioned the vestibulo-ocular reflex. The brain uses those canals, that bony canal system, and the fluid moving within it to automatically adjust the eyes. So again, you come in, you're feeling dizzy, you're feeling something. The questions you should get asked: how long is that dizziness lasting? How often is it happening? Is it better or worse with head movements? Is it better or worse with posture? Is there anything going on with the hearing, with fullness, with ringing in the ears, just because of how close the hearing and the balance system are physically? They work together, they share fluid space. So that's what we do to try to figure out, is this a problem that's affecting both those systems? Any ear surgeries? Have you had head traumas, medications? That all ties into diagnosing these disorders. One of the other things that we do to figure out inner ear is how long is that vertigo, or to focus more on vertigo, how long is that dizziness? How long is that spinning feeling happening? So one of the most common causes of that true vertigo spinning feeling is called benign paroxysmal positional vertigo. And you may have heard of this one if anyone you know has been told that they have crystals that are off. Those are those inner ear calcium crystals that are in one part of the balance system, fall out into the other part, the canal part of the system, and are telling your brain that your head is moving when it's not. Classically, this benign paroxysmal positional vertigo happens when you're moving. So it can be if you're lying down, rolling over in bed, looking up. It lasts usually for a few seconds. It doesn't it can be weaker. So the more you move your head, it may stop happening. So sometimes you get this feeling where it happens, then it goes away, not commonly accompanied by any kind of hearing symptoms. We diagnose these different things. I kind of go on to the next thing. We diagnose these disorders with position testing. So again, we use that anatomy of the balance system to see if those little crystals are out of place. The positioning maneuver is called the Dix-Hallpike maneuver. The physician or the physical therapist can move your head to the side and lay you back. There are classic positions that should trigger eye movements and let us diagnose this disorder. Depending on which balance canal the little crystals have fallen into, that will affect which way the eyes can classically move. So they can either move from side to side, they can move up and over, and it can be a subtle thing. So when you're lying back, you'll be feeling dizzy and feeling that vertigo, but the person evaluating you may say, keep your eyes open, because they're trying to see which balance canal it's in. This disorder, which I'll let Dr. Wazen talk more about, we can treat more positionally. Another thing to think about, though, is that benign positional vertigo in older adults might not present in that classic way where it's just short. Our patients that are older may feel more constantly out of balance. They may not classically get that spinning vertigo. So if you're coming in having any kind of problem with dizziness, we may check those positioning maneuvers just in case that's part of the problem. Benign positional vertigo is more commonly starting later in age. So it's more commonly we see it in patients that are 60 and older. It can be more common. You can get it more frequently as you get older. It may come and go. So it's something that it's important that we always look out for in all of our patients. So again, classically, that's a spinning sensation, happens with position changes that can often last a couple seconds. So looking at that length of time aspect. If the vertigo feeling, that spinning, is lasting a little bit longer, we start to think about different conditions. So for example, one is Meniere's disease, which is a problem with the inner ear and usually a problem with inner ear pressure. So that inner ear picture I showed you with the cochlea and the balance system, the fluid pressure inside can increase, and you can classically get problems with both those systems. So fluctuating hearing problems, fluctuating vertigo problems, ringing in the ear, and fullness, that all tend to change together. Sometimes our patients just get episodes of the vertigo and spinning that come and go, sometimes just hearing. Classically, it's all those symptoms together. We can do some tests to also further figure out if that's what's going on. You get a hearing test, you can check the balance system, check the inner ear pressure disease, and you can treat that. You can try to prevent these conditions and episodes from happening with restricting sodium in the diet, with going on a diuretic therapy, and then you can treat acute episodes with vestibular suppressants until we get you back on track. So you can see that different kinds of balance, dizzy systems can be treated in very different ways. That's why we try to get this history and get a good diagnosis. Another problem that can happen with the balance system causing that real spinning vertigo and also hearing changes that tends to last longer is what's called vestibular neuritis, or a neurolabyrinthitis, which is an inflammation of that same inner ear space, the inner ear balance system, or the inner ear balance and hearing systems. Those patients usually almost always have a cold leading up to this. The nerve and the inner ear system get inflamed, and those patients can have a spinning vertigo feeling for hours to at least a day, where it's really bad starting out, but then subsequently can have some weakness of the balance system that causes problems that linger. So these patients will still feel off balance even if they're not having the spinning vertigo feeling. Classically, they can still feel that something is a little bit off. On our testing, one side tends to be weaker than the other, and they can still have that reactive eye movement. And those patients, again, we treat differently, where you can decrease the potency of the balance system, decrease the sensitivity of it to decrease that really off motion sick feeling, and they can do some compensation training with our vestibular therapist or our balance therapists. Some diseases present with different lengths of time of vertigo, and I'll throw these out there just quickly as an example and as more examples of why it's important to keep track of what the feeling is, how long it's lasting, is it coming and going, is it positional? One is superior semicircular canal dehiscence syndrome, which is another problem with those balance canals we showed you the picture of. One of the balance canals, the one that goes up towards the brain, the bone between that canal and the brain can start to thin, and those patients will get sometimes a feeling of fullness, sometimes a heartbeat sound in the ear. Sometimes they can start hearing internal noises louder. They can start to hear their eyes move. They can get dizzy with certain pressure. Again, like a variable type of vertigo or dizziness. This syndrome is usually diagnosed with a CT scan to look at an image of the semicircular canal, and it can be treated with conservatively with avoiding triggers or with different kinds of surgery. Another kind of inner ear problem is a perilymphatic fistula, which tends to be more of a traumatic thing. It can be after a middle ear surgery, after a really hard hit to the head. These are the kind of problems you can get with deep sea diving or scuba diving, where if you come up too fast, it can cause more of an acute trauma to the middle inner ear. We've even had some people where they went too far in with a Q-tip that can cause this kind of thing. So that's why we as ear doctors really don't like Q-tips, because we've seen some bad things happen with them. The reason we are always on the lookout for something like this and those triggers of a real damage to the inner ear is that those are treated with surgery. So those patients can also get a vertigo type symptoms, but tend to have a more clear trigger. And then the last vestibular kind of disorder I want to talk about that's more inner ear brain related is a vestibular migraine, where our patients that have a history of migraine headaches, the more classic one-sided headache, sensitive to light and sound, that tend to last anywhere from hours to a few days, can also have a vestibular inner ear symptom associated with that. They can have spinning vertigo, they can feel off balance. Sometimes as you start preventatively treating for migraines, those balance symptoms also get better. So classically, to get diagnosed with a vestibular migraine, you do have to also have either migraine headaches at the same time or a history of migraine headaches. And we treat those similarly to migraine headaches. And then one of the things we also see and we treat to tie this in together is an age-related vestibular dysfunction, where we talked earlier about how complicated the balance system is, how all those systems, vision, the inner ear, strength of the body, sensation of the body, vestibular, like balancing reflexes, the vestibular system that moves the eyes, all of those can start to take hits as we age, either with other medical problems, just slowing of generalized reflexes. And that can tie into when you come in and you're feeling off balance, you feel off when you walk. We look at those inner ear problems. We look at the medications you're taking. But sometimes what the important things to do is to bolster the parts of the balance system that we can work on, maximize safety at home, strengthen the body, do exercise programs, Tai Chi, walking, improving vision, improving hearing, doing whatever we can to help the balance system along. And that's where part of our vestibular rehabilitation ties into that particular treatment of dizziness. So that's, okay, I'm doing on time, we're doing good. That was an introduction on my end from a medical perspective of what we think about when you're coming in with balance disorders, with vertigo, how we try to diagnose what it is, a look at the different more classic inner ear vertigo syndromes, and then just tying balance in with all those other systems.
Am I on?
Yes, ma'am.
Well, hello, everybody out there in Zoom land. It's so exciting that there's so many people who are interested in learning about vertigo and what are the causes and what are the treatment. And Dr. Fechtner, thank you for telling us so much about the different ways that doctors think about dizziness and vertigo problems. But I want to talk a little bit about how physical therapists think about these problems. Let me see how I'm going to advance my slides here. Okay. Can you advance the slide for me, Christina, or should I do it from here?
It's on yours.
It's on yours.
It's open already.
Okay. Ta-da! I figured it out, guys. So Dr. Fechtner was so great at describing the inner ear system. And of course, we have two ears and they act like gyroscopes that tell our brain whether our head is moving, or they can tell our brain if our body is moving, or they can tell our brain if we're basically sitting perfectly still, but maybe we're in a car that is moving with a bumpy ride. So our vestibular system is really one of the primary organs of balance. And it's what we need to have working properly in order to prevent falls. So, of course, if somebody is having vertigo, they're at really high risk for falls. And I wanted to talk a little bit more about falls since it's so important. Where do I share my script? Christina, come and help me for a second. Share. And then you have to select, are you on the Zoom, right? We're figuring things out. So falls, while Christina is figuring this out, maybe I'll talk a little bit more about falls. How many of you guys know somebody who's fallen in the last year? Show of hands. How many of you out in Zoom land have known somebody who's fallen and been seriously hurt in the last year? Raise your hand. As people start to get older, the incidence of falls increases. And so we can look at statistics to learn a little bit more about falls. For instance, the Center of Disease Control and Prevention gives us this information about falls. They tell us that 1 out of 5 falls ends up causing serious injury. Falls are the most common cause of traumatic brain injuries. And, that costs a lot of money. If you have a traumatic brain injury, you have a fall, you have a fracture, you hit your head, well, you're going to go to the emergency room. And chances are you're going to need a lot of intervention to help you recover. In 2015, the total medical costs for falls totaled more than $50 billion. And 75% of these costs were covered by Medicare or Medicaid. Okay, so let's go to the next slide. Okay, here we are. So each year, millions of older people, and I think we should make, I don't know, are you older if you're 65? I mean, that seems kind of young to me, but the CDC is looking at people who are 65 and older. And what they're finding is that 1 in 4 people in that age group are falling every year. But guess what? Only about very few of them, less than half, are telling their doctor that they're falling. So if you're not sharing that with your physician, then you're not going to likely be referred to a place like First Physicians Group, where we can figure out why you're falling and what to do about it. Falling doubles your chances of falling again. So that's all very depressing talking about falls. But you know, not all older people are falling. This is my friend Peter. Actually, I met him when I was out in Colorado at a lecture. Thank God I had a little bit of time to ski. And I knew I was going to have to talk to a group about falls. And I see this gentleman walking by, and I don't know if you can see it, but he has a little patch on his jacket and it says 90 plus ski club. So I had to introduce myself. He says, yeah, you know, to be in my group, you have to be at least 90 years old to be in my ski club. And he was 92 at the time. So just because you're getting older doesn't mean that you're going to have poor balance. But what was Peter doing that was helping him maintain his balance as he was getting older? Well, let's talk about the balance system. How does it work? Well, for one thing, we have sensory input. So what does that include? That includes our vestibular system, our inner ear system. We also get visual information that tells us how to respond to our environment. If I walk outside and I see that the sidewalk is crooked, my brain is taking that information in and planning how am I going to negotiate those uneven surfaces that I'm approaching. We also have proprioceptive input. What is that? That's the nerve endings that are in our joints and in our muscles that tell our body what position we are in space. So like, for instance, I'm sitting down right now, but I don't have to look at my body to know that I'm sitting because my joints and muscles are telling my brain that I'm sitting. We also, I should have put hearing down because hearing also helps us know what's happening in our environment. So our brain is getting all of this sensory input, and then it has to analyze it and immediately tell our body what to do to maintain our balance. So it sends a motor output through the nerve endings. That's a neurological output that goes to the muscles that are part of our muscles that are attached to our skeleton. And that connection is called a neuromuscular connection. And it tells our body what to do to maintain our balance. Our brain has to process this information very quickly. That's called your reaction time. How quickly can you get information, process it, and tell your body what to do to maintain your balance? So obviously, Peter was doing a good job at using his sensory input and then processing the information with a really good motor output so that he could ski and have a great active retired lifestyle. Vertigo, that's the subject of today's talk. It's a spinning sensation where people think that things are spinning around them or that they are spinning. And if you have a spinning sensation, it's very specific to the inner ear system, and it can result in falls and injury. So how would you know that somebody is having a balance problem? What are signs that you might experience or your loved ones might experience that would tell you that there's something wrong with my balance and I have to get it checked out? Well, if you're walking and holding onto furniture, touching the walls, touching the back of the chair, that's a sign that a person is having a balance problem because you shouldn't need to do that. If you try to get up from the chair and it takes you 3 or 4 trials to get up from the chair, then obviously you're having some type of strength or mobility problem. If you flop when you go to sit down, or if you're having difficulty walking on uneven surfaces, like for instance on the grass or on cobblestones or on the sand at the beach, that would mean that you're having a balance problem. If you struggle to go up and down a curb, if you have a fear of falling, if you have too many accidents, or if you're veering when you're walking. Did you know that falling isn't normal when people get older? I always ask people I'm meeting with, how many times have you fallen in the last 12 months? I had one person say, oh, not that many. I said, well, how many is that? They said, I only fall about once a day. Once a day? That's crazy. Medicare tells us if somebody falls once and is injured, they should have their balance checked. And if somebody falls twice within a year, that's another red flag that they're having a balance problem and they need to come in and talk to their doctor about it. And perhaps they'll see a physical therapist as well. Let me see if I can advance the slides again for us. For some reason, it's being ornery again. It's not working on it. It's not working with my little arrows. Let's see. Okay, there we go. So vestibular rehabilitation. What does that mean? That means that you're seeing a physical therapist who specializes in treating people who have inner ear problems. And I wanted to talk about what can you expect when you are sent for a physical therapy evaluation. Well, first, we're going to start with the history. What's happening with you? After we talk about that, we're going to check your flexibility because you have to have a certain amount of flexibility to move in a normal way. You also have to have a certain amount of strength. So you could have the most amazing inner ear system and your brain could be fabulous at processing information, but if your legs are weak, then you could still be having a balance problem. So we're going to check your strength. We're going to check your sensation. You know, when I'm standing, I can feel my weight shifting from the right foot or to the left foot. But people who have sensation problems, particularly those who have peripheral neuropathy, may not get the same sensory information that normal people do to help them balance. So we want to check that. We want to check and see how does the person use the inner ear information that tells the brain that the person is moving their body or moving their head. How do they use that information to coordinate their eye movements? So that's what gaze stabilization testing is about. Dr. Fechtner mentioned that some people have the crystals out of place in their ear. I'll bet a bunch of you have friends who told you a story about how you went to the doctor and your crystals were out of place and they moved your head, put them back in place, and then things seem to work better. So we're definitely going to check for that because it's very, very common in people over the age of 65 or people who are complaining of dizziness. We're going to look at your balance when you're standing still and when you're walking. But it all starts with talking to your medical provider. So what do we want to know when we're talking to you guys about a dizziness problem or a balance problem? We want to know if there's any pattern to it. Is it a new problem, an acute problem? Is it something that comes in spells? Dr. Fechtner was saying that, you know, there's lots of types of vertigo, but there's some that only last for seconds. Others only last for minutes. Others last for hours or days. So we definitely want to find out what would be your pattern of your symptoms. Symptoms can also be described as nausea, floating, rocking sensations. Oscillopsia is a condition where the inner ear system isn't sending information anymore. And so the brain doesn't know how to coordinate the eye movements. A person who had oscillopsia would describe that when they're walking, that it seems like the world is bouncing. Kind of similar to how if somebody ever showed you their vacation videos where they have a video camera and they're walking and they're showing you the Grand Canyon or something like that. And because they're walking, the screen is bouncing. Well, that's what someone with oscillopsia would feel in real life. Disequilibrium means that the person isn't necessarily complaining of dizziness or vertigo, but they're still unsteady. People can have changes in their hearing, ringing in their ears, and we spoke about falling already. We want to know, does anything change your symptoms? Are there certain circumstances? Do you get dizzy or unsteady when you're walking in a dark environment, when you're walking in a crowded, busy environment? Does it happen just out of the blue? Does it happen when you change positions? Does it happen when you move your body or your head? And do you have any history of motion sickness? After we've talked about all these things, it's time to start testing your balance. One test that we do is called a Romberg test. The person is standing with their feet together and their arms across their chest, and we want to see how steady they are with their eyes open and also with their eyes closed. Really, we're looking to see, can someone stand for at least 30 seconds in these conditions? If they're unable to do that, then that's a sure sign that they're having a balance problem. If they can do it with their eyes open, but they can't do it with their eyes closed, that means that that person is visually dependent and is not doing a good job using their inner ear system. And that could lead to falls if you were walking in a dark environment. A sharpened Romberg just means that the person's standing heel to toe, and we check and see how do they maintain their balance when they're standing in a more narrowed position. How does a person maintain their balance when they're standing on one leg? People often do that when they're putting their pants on in the morning. People have to stand on one leg when they go to step up a curb. So people who are afraid of falling on curbs may not have very good balance when standing on one leg. And that's something that you could work on with your physical therapist. We're not just standing still, we're moving dynamically. A physical therapist will look at your walking quality. We'll see, is your self pace a normal pace? Or is it super slow? Or is it too fast? We want to see what the quality of your movement is. Are you shuffling your feet? Are you veering? Are you taking a normal size step? Are your steps inconsistent? Are you crisscrossing your feet? If you walk and turn your head, does that cause you to veer? Do you veer only in one direction? I had somebody today, I evaluated them and they're walking and I asked them to look right. They look right, no problem. I asked them to look left and they're staggering. So we look for those patterns. We look to see how people do when they have to turn, when they're walking and they have to make a 180-degree or a 360-degree turn. We have people walk on soft surfaces. Here in Sarasota, we're lucky, we have beautiful beaches. So we want to make sure that if one of our patients goes to the beach with their family to see the sunset, that they're not going to fall when they're walking on the sand. So we have them stand on foam with their eyes open or eyes closed. Because this is a center of excellence for treating and diagnosing vertigo problems, we have very specialized equipment here that can give us more information about the inner ear system. One piece of equipment is called computerized posturography, which I have a picture of later. We can also do motion sensitivity testing, where we see if certain positions provoke dizziness or vertigo. And we can also look at people's balance when they're walking heel to toe, which is like the typical sobriety test. Here's a picture of the computerized posturography machine. I'll bet there's some people in our audience today who've had the pleasure of doing this test. They're strapped into the top of the device. They have this jacket on like they're about to jump with a parachute so that there's no chance the person could fall. The platform the person's standing on has motion sensors that let us know if they're swaying. There are times during this test where the person's eyes are open and their eyes are closed. There are times where the surface can move or where the visual surround can move. This helps us understand how a person is using their vision, their inner ear information, and the sensation in their joints and muscles to help them balance. That way we can determine if the person's brain is doing a good job at using all the information or if there's certain types of information that they're struggling with. Gaze stabilization testing is something that we can do with a bunch of fancy equipment, or we can also do it just, one-on-one. In this picture, the therapist is holding the person's head and moving their head to see if they're able to maintain their eyes on the therapist when the head is in motion. People who can't do this will complain of dizziness. So it's something that we must check when we work with patients. This testing is some of the fancy equipment that we have here. it's really great because it'll help us test the ears separately so we can determine, is the person having normal inner ear function in both ears, or is one ear weak? Unilateral versus bilateral. Now, I always think about this when I'm evaluating a patient. It's kind of like an airplane, right? An airplane has an engine on each wing, just like people have an inner ear system on each side. So imagine you're in this airplane. Both engines are working. The plane should fly straight. But what if one engine cuts out? The pilot can still land the plane, but that plane is not going to be flying very straight, okay? Because it's only working with one engine. If both engines cut out, if you have a bilateral problem where both engines are weak or both engines are not functioning, then you're in trouble. So when we look at our patients, we want to know, are both inner ear systems working? Are they equally strong? Is one weak, or are both of them weak? There are conditions that affect both ears, and there are conditions that affect only one ear. So the inner ear system, the balance part, is right next to the hearing part of the ear. And the hearing part of the ear can also give us some good information. Some of our patients have hearing loss. Some of them don't. Positional vertigo, which is called BPPV, the long phrase for this is benign paroxysmal positional vertigo. If somebody comes in and tells me they have vertigo and at the same time they're losing their hearing, well, guess what? They don't have BPPV. They don't have a problem with their crystals because BPPV has nothing to do with hearing loss. Vestibular neuritis is not associated with hearing loss. Bilateral hypofunction, you could have amazing hearing, but still have both ears balance system not working. Concussion doesn't necessarily exist with hearing problems. But MENERE'S disease, labyrinthitis, bilateral hypofunction, acoustic neuromas, or trauma, oftentimes these patients have hearing loss as well. So, of course, we are experts here at diagnosing vertigo and at diagnosing inner ear problems. But if I want someone to get better, I have to make a plan that includes all of the challenges that they're having. So I'm going to screen that person for visual problems, hearing problems, central nervous system issues. I'll look to see if they're showing any signs of peripheral neuropathy. I'll check their musculoskeletal system to see if they're strong. And you know, having all these problems isn't easy. Oftentimes our patients have a lot of anxiety because it's hard to manage your day-to-day function when you're having all these problems. And because we take a holistic approach, it's important to understand psychological issues like anxiety, because oftentimes if we can treat the anxiety, it makes it a lot easier to participate in physical therapy and to recover. So we've done all these evaluations, and the physical therapist's job is now to determine what are the list of problems, what are the good things that we don't need to work on, and what are the things that we need to list in our problem list and to set goals. I always want to ask the patient, what is your goal in coming to physical therapy? I want to make sure that the goals I'm making meet the goals that they want to achieve. I'm not going to make a goal for them to run the Boston Marathon if they hate running. So it's really important to talk with your therapist about your daily life and what you want to improve. It's also important to be realistic. You know, if you said your goal was to be an Olympic athlete and you're 55 years old, chances are you missed the boat on that one. We want to talk about how long will it take for a person to get better. I'll let the patient know at the end if I think it's going to take 4 treatments, 8 treatments, 10 treatments. How compliant is the patient? What do I mean by that? Well, you don't just get better by coming to see the physical therapist. The physical therapist is going to give you exercises to do to work on all of the balance or strength or dizziness problems that you're having. So the patient has to do their exercises if they're going to get better. In physical therapy, the balance exercises are the medicine. And if the patient doesn't take their medicine, how could they get better? We're going to write goals to help you work toward your improvements, and we're going to periodically check in and see, are you meeting your goals? Are you moving towards the expectations of overcoming your vertigo and balance problems? When we select treatments as physical therapists, it's based on the information that the audiologists, that the physicians, that the tests, and that the physical therapy exam has told us about the person's potential to get better. If I pick an adaptation exercise, what I'm doing is trying to teach the patient how to use the inner ear function that they have and how their brain can process this information to have better balance. However, if somebody's inner ear system is completely shot, completely absent, there's nothing we can do to make that inner ear information any better, then I need to help that patient learn ways to substitute for the lack of inner ear information that they have. They'll probably rely more heavily on their visual information. So I may say, hey, look, carry a flashlight in your purse. And if you go to a restaurant and it's too dark, use that flashlight to enhance your vision so it makes it easier for you to balance. That would be an example of a substitution. Using a cane or using a walker is using a device to help you compensate for a lack of inner ear balance function. Sometimes with dizziness, people have to habituate. We have to expose them to the condition that's causing their dizziness so that their brain can learn how to process the information so that they're not dizzy when they're exposed to whatever the particular stimulation is. And cannula repositioning maneuvers are the treatments that Dr. Fechtner was referring to when we do treatments to put the crystals back into the proper place in the ear when a person's diagnosis is positional vertigo. So strengthening, always going to be in our plan if you show any sign of weakness. You know, muscles are use them or lose them. So when you retire, don't spend your life on the sofa watching TV or playing mahjong and reading books and all this. That's great. You can do those things, but you also have to be active and you also have to use your muscles to stay in shape. So if a person had weakness in their legs, we would give them exercises to do. These ladies are in an exercise class, and right now they're doing an exercise to strengthen their thigh muscles. The vestibular ocular reflex is the reflex that happens when the inner ear system sends information to the brain to tell the brain that the head is moving, and then our brain uses the information to keep our eyes on a target. In the picture on the left, the person is moving their head up and down. So the inner ear system is sending the information that the head is moving up and down, and then the brain is using that information to keep the eyes on the target, which is the little black stick that the person has in front of their face. We also use this information when the head is moving side to side so that we can turn our head and keep our eyes on the target. The vestibular therapist almost always includes these exercises in the exercises that the patient needs to practice at home. And as the exercise gets easier, we work at moving the head faster to still coordinate the head and the eyes with faster movements to prevent dizziness when the person is moving about. We can give them standing balance exercises. We can give them strength and balance exercises, since it's just going from a sitting to a standing position, for instance. We always include walking exercises, and we make sure that we train the person in how to improve the impairments in their walking. The more that you're able to walk, the more healthy you're going to be able to become. They always say walking is the best exercise. So we want to make sure that you're walking properly and that you're not shuffling your feet or scuffing or doing something that could cause you to fall. Here's the test for positional vertigo, where we turn your head to the side and lie you back and look to see if it provokes vertigo and abnormal eye movements. And treating the crystals requires having the person lie back. The therapist will then move the head in the proper position to redirect the crystals back into the proper part of the ear and have the person sit back up. You know, we have 3 canals in the ear, and if you don't know where those crystals are, then you really need to come and see a physician who knows how to do this treatment, or a physical therapist who knows how to do this treatment so that we can move your head in the proper way to guide the crystals back into place and get rid of your vertigo or dizziness. This lady gets dizzy when she lies down and sits up. She doesn't have a problem with her crystals, but she is very sensitive to going from sitting to lying. So we gave her a little exercise where she would do this repetitively, lying down, waiting for the dizziness to pass, and then sitting up, waiting for the dizziness to pass, so that her brain could get used to this stimulation to the point where it wasn't provoking dizziness anymore. If you're a person who doesn't like to exercise, sometimes it's helpful to find an exercise buddy. I know when I make a date with my girlfriend that we're going to go for a walk down at Marina Jack's, even if it's hot and I don't feel like it, I'll go because I know that I don't want to let my friend down. So find an exercise buddy if you're one of these people that don't enjoy exercising. Find times to walk where it's nice and cool out. If it's too hot in the summer, which goodness knows it is right now, maybe walking at the mall in an air-conditioned environment would be a good idea. So tips for preventing a balance problem. Find a hobby that gets you up and off the sofa. Find something that you enjoy that helps you move your body and maintain your strength and wellness in your cardiovascular system. Keep your muscles strong. Walk every day. Eat right. You have to put good food in your body to stay healthy. Consider doing Tai Chi or yoga or ballroom dancing. Join a gym. The benefits of seeing a physical therapist are that we have college degrees in what we do. As of 2020, physical therapists have to have a doctorate's level training to work with people. And at the Silverstein Institute, the ENT group for First Physicians group, we specialize in treating inner ear problems. So going to a general physical therapist is not going to fix the problem when somebody has vertigo. So I want to thank all of you guys for coming today. It means that you're interested in vertigo, you're interested in what you can do to be healthy and well, and you're interested in knowing what physicians who are specializing in inner ear problems and what physical therapists who are specializing in inner ear problems can do to help you or help your loved ones who are having a problem. So I think what we'll do is we'll open it up for questions. I want to say that, there's a lot of people in the audience. And so I think if you're going to ask a question, you should ask a question that would be meaningful for everyone in the group. If you have a question that's very personal, that requires a lot of talking about personal symptoms that you are having, maybe it would be better to come and see us one-on-one and just to ask questions right now that everybody could benefit from. So I'm going to hand it over for questions now.
I do have one question. How do you differentiate anxiety-induced vertigo versus anxiety as a result of vertigo?
Oh, so did you write that question out for them? So there's a,
Could you repeat the question, please? Because it was very hard to hear.
There's a question that has to do with, can anxiety cause vertigo, or does vertigo cause anxiety? It sounds like a little bit of a chicken in the egg kind of question. Do you want to talk about that, Dr. Fechtner?
I can speak on that briefly. So I agree that is a very chicken and egg question. I think the way you would tell it, one, is what we talked about a little bit, talking about history, trying to figure out when it started. But one of the things you definitely want to do is to do the physical exam and testing to look for a disorder that causes vertigo. So you can do your tests. Well, we look at the balance system, you do your position testing, and we see if there is an inner ear problem. That's easy enough to diagnose with our tests. If you find something, then that's more convincing that the underlying cause is an inner ear or vertigo problem, and then treating that problem should alleviate or help the anxiety. The other side of it, sometimes Anxiety itself can cause lightheaded, dizziness, vertigo problems. Some of that ties into anxiety leading to hyperventilation, breathing faster. That changes concentrations of oxygen and CO2 in the blood, and that makes you lightheaded. It can increase cortisol levels that can cause a feeling of vertigo. So you can see why those two symptoms can be very close together. But I would say the short answer to it is that you look for an inner ear or vertigo problem. If you treat that and that helps the anxiety, that gives you your answer. If you don't find anything on the workup that's more convincing that the anxiety itself can be the root cause.
Great. Well, it looks like we don't have any other questions right now. So I guess that means we may have done a pretty good job of explaining some of the stuff today. But if you have questions that come up and you want to come and see one of the physicians here or see one of the physical therapists here, we're a resource for the community and for the Ear Research Foundation, who I really appreciate them putting together this educational series, because that is one of the missions of the Ear Research Foundation, is to be a resource to the community, especially people who have hearing and balance disorders. So shall we wrap things up then? Yeah. All right, guys, it was great seeing you today. Thank you, Dr. Fechtner. That was an awesome talk. And thank you, everybody, for coming to our meeting.
Thank you. Both.